Welcome everybody, this is Yasser Wasifi again from Learn Dental series. In this episode we will continue our discussion about direct tooth colored restorative material composite resin, especially in terms of tooth preparation. I would like to clarify firstly and declare that I don't receive fees, compensation or royalties from the sales of any of the products shown or discussed in this presentation. Also, I haven't any conflict of interest with any of the discussed products or the technique. Also, I would like to announce again that this presentation is copyright protected and any part of it could not be reproduced or used either by electronic or mechanical means without a written permission of me. Today, as I mentioned now, we will discuss the tooth preparation in terms of general concept of tooth preparation, designs of tooth preparation, and clarify the general features for class 1, 2, 3, 4, and 5 to receive composite resin as a direct tooth colored restorative material. Let us start with the general concept of tooth preparation, and remember that composite is a bonded material that undergoes shrinkage. That's why our first concern is to conserve as maximum as possible tooth structure. Tooth preparation is only limited to the defective, to involve the defect and the defective tissue. That's why extension for prevention and proximal contact clearance is not necessarily in such case, unless you are in need to increase the clearance of proximal contact just to allow you to insert your proximal matrix, okay, and restore properly the contact area. Also, your preparation having a variable depth, okay, of bulbal and the axial depths, okay, only limited to the extension of the caries. Also, you should consider the proper preparation of operating site, because this preparation will receive bonding procedure, okay. That's why your tooth surface should be roughened in certain cases, okay, just with diamond abrasives, just to increase the bonding ability to the tooth structure. Enamel bevel may be given in certain cases, okay, to increase the surface area of etching and bonding, while the cavo surface margin, especially at root surface, should be butt joint. What about the enamel bevel? Enamel bevel means that you are increasing the cavo surface angle more than 90 degrees, as we previously mentioned in the topic of fundamentals of tooth preparation. In such a case, you are adding enamel bevel to increase the surface area of acid etching, to expose the enamel rod ends rather than sides, which is much more easier to be etched, okay, and produce a reliable effect on bonding with enamel, okay. Also, it provides some sort of optical illusion that will delete any line of demarcation between the restoration and the tooth structure, okay. But remember that composite is not a ductile material, is not a high strength property material compared to that of the gold. It's considered as a brittle material. That's why how it could be applied on enamel bevel, okay. That's why it is contraindicated to cut an enamel bevel in areas receiving high stresses, okay, or in areas of centric holding areas. And that's why you should, when working with posterior teeth or occlusal surfaces or palatal surfaces subjected to force and having centric holding areas, first of all you should using articulating paper to determine the centric holding areas and avoid beveling of cavity margin at this area. It is better to avoid placing all your margins and at this area, as we mentioned before. Similarly, enamel of the gingival floor, which is very thin, should not be beveled. Why? Because already it's very thin. When you are beveling it, you will completely chip all the enamel and your margin will get down to the gingival, and maybe it became on cementum rather than on enamel and dentine, okay. When you drive it to be downward, okay, this means that you are irritating the gingival tissues, there is a difficulty to isolate this area, and all your bonding procedure will fail. Okay, at the same time, there is no light curing that will reach to this area subgingivally. Okay, also bonding with cementum is very difficult, while the maximum bonding is recorded to be with enamel, and your cavity should have enamel margins all over your cavity, which provides maximum bonding with the tooth structure. This is the enamel bevel and roughening your margin with diamond abrasive point. Okay, and this is the acid etching. It is performed or cut at the labial wall of class 3, as you could notice from this photograph, and this is the finished case. You could note that there is no line of demarcation in expense of your shade is perfect. Okay, but you couldn't notice any line of demarcation, and this is one of the functions of your bevel, or one of the advantages of using bevel. Then this is an occlusal cavity without any bevel. Okay, just etching your enamel margin that has cavo surface angle 90, because you couldn't bevel this enamel margin. As a result of you may get fractured composite because it is brittle and the margins are subjected to high occlusal stresses. Also, you could note in the first left one, okay, how thin is enamel, which appears as just a white line, okay, at the area of the gingival floor. If you bevel it, it is completely chipped, and you are now bonding with the subgingival cementum margin of your root. Then applying our etching without beveling the gingival enamel. Then what are the common designs in general for tooth preparation to receive composite resin restoration? We have mainly three designs, which is the conventional design, then beveled conventional, and finally the modified design or conservative, also called adhesive design. Okay, let us start with the conventional one. Conventional one is similar to preparation for amalgam or for any brittle material, with the exception of minimal extension of cavity walls, okay, and margins, and at the same time roughening of the cavity walls to motivate or to improve bonding to the tooth structure by using diamond abrasive. Okay, this is indicated mainly when you are dealing with a root surface preparation, okay, or when you have moderate to large class 1 or class 2. The features of this design is that enamel margin is prepared by 90-degree cavo surface angle, which is called butt joint margin, okay, especially on the root surface, and the prepared tooth surface is then roughened with to increase the bonding. Okay, mainly it is similar to that for, or to the specs for preparation for amalgam restoration, okay, but only it is with limited extension or with maximum conservation of tooth structure. Then comes the same cavity, which is called beveled conventional design. Then it is a conventional one, but with supplied with enamel bevel in areas not subjected to stresses, okay, indicated when you are using composite resin to replace an existing restoration, either defective or not, okay, which already inserted into a conventional cavity. Then you already have a prepared cavity, you just removed the restoration, then just you added enamel bevel in areas not subjected to stresses to improve the bonding with the tooth structure. It is indicated to restore large preparations, and especially indicated for classes 3, 4, 5, and sometimes 6, okay, but not class 1 and 2, because you couldn't perform bevel in such cavities because its margins and its tooth restoration interface is subjected to occlusal forces. The features is just a conventional cavity, okay, with enamel margin having a bevel in non-stress holding area, okay, and again this bevel is prepared with diamond abrasive point to increase the roughness and motivate much better or enhance much better bonding with the tooth structure. Then comes the recent one, which is the modified design or conservative design, okay, or also adhesive design, which is the most conservative one in nature, okay, and its retention rely on micromechanical bonding with the tooth structure. It is indicated for the initial or small carious lesion. Your preparation is just a scoping of your defect or your carious lesion, okay. It doesn't have any specific wall configuration, okay. Extent and depth of the preparation depends upon the extent and depth of the lesion. Just create an undercut and it is a scoped out appearance. Those are the three available designs. Number A is a conventional design, number B is the beveled conventional, while the modified or conservative design, which is scoped out tooth preparation, okay, appears in figure C. Let us go for much more further details, okay, and discuss different cases for class 1 cavity preparation. For class 1 cavity preparation, an occlusal surface already subjected to occlusal stresses, preoperative consideration should include marking, as you could notice now, okay, the centric holding areas, which should be away from the restoration margin, okay, and should not be beveled. And actually, you shouldn't bevel any margin at the occlusal surface. That's why you should mark the centric holding areas using articulating paper before you start your preparation. And if it is erased by the action of water coolant, okay, again identify it, okay, by re-identify it by articulating paper. Then when you're considering the tooth preparation, the general rules, you need to create access to the faulty structure, remove faulty structure, then creating convenience form to access or to enable you to restore the tooth easily, okay. When you are when placing most posterior composites, okay, it is not necessary in such case to incorporate mechanical retentive features, okay, and to insist to cut more tooth structure. Just make it with undercut, just make it wide internal outline, wider than that of occlusal outline, okay. And the other additive mean of retention is aided by the bonding with the tooth structure, especially if you select a bonding agent with high bond strength rather than that of polymerization shrinkage stresses of the composite. For simple to moderate class 1, it's a minimal invasive preparation, just limited to the area of the lesion, either in extension or in depth. Your cavo surface angle may result into appear to be flared without uniform flat bulbal or axial depth. The initial bulbal depth is determined by selective removal of only carious lesion, typically the same as this preparation. Just access it with round burr, excavate as much as possible from your dentine, selective removal of soft carious dentine, then without beveling, okay, without definite width, definite depth of the cavity, okay, definite configuration, just cut as conservative as possible, okay, just etch your enamel, apply bonding agent, apply just a stress breaking base if required, otherwise start to restore your tooth with your composite. For moderate to large cavities, okay, the objective of tooth preparation is to remove the carious tissue or faulty restoration as conservative as possible. It may has flat walls that are perpendicular to the occlusal forces with cavo surface angle, okay, 90, just to allow proper marginal configuration, okay. But you should remember that this cavity design, which nearly box, it's not a true box shaped cavity, but it violates the C factor we discussed before. That's why the technique of placing your composite, okay, should be incremental, okay, should allow much more free surface to direct your polymerization shrinkage, as we discussed before, towards the free surface. Okay, you should also improve the adaptation by using flexible base material that act as a stress breaking one, like glass ionomer cement and flowable composite. This is a case of recurrent caries under amalgam restoration. Okay, we removed the amalgam, getting access to the carious lesion, removal of the carious lesion, spot removal. Okay, I am not intended just to flatten the bulbar floor. Okay, it's of no matter, it's unnecessary. Okay, it doesn't affect if you have, as we mentioned, if you have a dentine ledge or not. Okay, because it is a bonded restoration and it will not rock inside the cavity depending on the bond strength of the dentine bonding agent you used. Then after spot removal or selective removal of the carious lesion, acid etching, bonding procedure, applying stress breaking liner to reduce the amount of composite used and to decrease the C factor. Then apply your composite in incremental backing technique with minimal increment thickness. Okay, and finally, this is the final restoration. When we considering class 2 cavity preparation, the preoperative consideration, okay, should focus on and insisting on avoiding injury of the neighboring tooth surface. This is number one. And one of the most important factors is to determine the gingival extension of your preparation to avoid violating the biological width and at the same time to provide maximum bonding with the gingival floor. That's why you should evaluate your extension gingivally. That may necessitate either to go for deep margin elevation, like this case, when you go to get a radiograph, bite wing radiograph to determine it, then excavation. Okay, you discovered that your margin is equigingival. Okay, still within the gingival sulcus, but it may be deepened to reach its depth, to reach its sulcus, the sulcus depth. Okay, in such a case, we apply our rubber dam. Okay, gingival retraction cord. Okay, trying to displace the gingival tissues just a little bit deeper, just to facilitate to and allow us to apply a base material. Okay, like resin modified glass ionomer cement. Okay, just to elevate your margin that appears like this to be supragingival rather than subgingival. Then continue with your composite, and this will be the final result. This is the preoperative, this is the margin elevation, and this is the completed composite resin. And we said that this is termed open sandwich technique. Okay, or deep margin elevation. Your margin may be not equal, maybe not at equigingival. Okay, maybe at the base of the sulcus. Okay, and when you are going to excavate the lesion, you may, at this condition, you may injure it or tear or destruct the attached epithelium, which will lead to in turns, okay, to violation of biological width with tearing of attached epithelium, leading to increased pocket depths, leading to furtherly for bone desorption and mobility of your teeth. In such a condition, we may need to consult a periodontist, okay, just to go for or arrange for crown lengthening, okay, just to deepen your attached epithelium level without endangering, okay, the biological width and creating a new biological width, which is called surgical crown lengthening. And as you notice that in such a condition, it seems that your margins are elevated, okay, and you could excavate it properly, you could design your cavity properly. Those are two important issues that should be considered when you are preparing class 2. Again, never to injure the neighboring tooth. You should think how to protect neighboring tooth, either with Teflon, with rubber dam, whatever what you use, okay? And think about the gingival extension of your caries in order to avoid any violation to the biological law. Then your tooth preparation aims to, okay, the general rules like that for class 1, creating access to the lesion, removal of the faulty structure, creating convenience form, okay, with concern to maximum conservation of the tooth structure, okay. Obtaining access to the defect may include removal of sound occlusal enamel for access, but no need for bulk strengths in such a condition because already you used a bonded restoration and your bond will help in retention and resistance form. No need to cut extra features of your cavity. Then, if your cavity is a small proximal lesion, okay, it may be with conservative design with proximal box preparation or proximal slot preparation. Conservative design, it's just removal of the initial surface of the carious lesion, which is very initial, okay, or removal of initial restoration, okay. The objective is to remove the carious lesion or defect conservatively. No bulbal or axial depth is definite. It is just dedicated only by the depth and extension of the lesion, no necessarily to be uniform. Your proximal extension is dictated only by the extent of the lesion and just create a cavo surface margin, okay, with 90 degree, and sometimes it may be greater a little bit, okay. This is our initial proximal lesion. Just remove it with round burr or with 330 burr, okay. Just remove the undermined enamel, okay. Roughen your enamel wall using diamond abrasive points, and this is all, okay, the preparation. If the preparation in such a case, okay, it may be you have a previous restoration, okay, it may be it is much more extended beyond the contact in a gingival direction. In such a case, let it have a box shaped design, okay, indicated when the proximal surface is defective with no lesion on the occlusal surface. That's why you are not in need to cut an occlusal outline. You just access it from the marginal ridge, okay, creating cavity walls and the floor, while their axial depth and gingival extension of the gingival floor is dictated by the extent of the lesion. Again, no need for beveling or secondary retention is indicated. Sometimes in old aged patient where there is a gingival recession, okay, they may have what is called senile caries interproximal, which is mostly related to the cervical line area, and sometimes it may involve the root, okay. In such a condition, you may access it without endangering or without cutting any occlusal access, okay, for convenience. You may access it through the gingival embrasure, entering it from the facial area or from the lingual area, preparing it in a form of slot cavity preparation. But you should take care not to undermine the marginal ridge, otherwise it will be a box-shaped cavity. Just like this case, okay, you may access it from the buccal or lingual according to the extension of the caries and which one is accessible, okay. It is just a slot cavity preparation, mainly for old ages with gingival recession, okay, and it will be above the gingival, the biological width of this case. In case of moderate to large class 2 cavity, then you will cut a classical class 2 cavity similar to that of amalgam, but with minimal extension, and also cavity depth, cavity extension is dictated by the extension and depth of the defect and of the carious lesion. Then comes class 3 cavity preparation. Class 3 cavity preparation the preoperative consideration as any proximal cavity, the same as class 2. Tooth preparation also aiming to obtaining access to removal of the defect and creating convenience. For tooth preparation for class 3, you may have to access the lesion either from the lingual or from the facial. Mainly from the lingual approach is preferable, okay, as it provides us with many advantages. Okay, you could conserve the facial or labial enamel, okay, which you could, as we mentioned in the chapter of fundamentals of tooth preparation, okay, you may leave the enamel wall undermined, labial enamel wall undermined for the purpose of aesthetic, but not friable. Okay, it is undermined, unsupported, but not friable. Okay, just left on the facial surface in for concerning the aesthetics of the tooth. This will allow the shade matching of the composite will be less critical. Discoloration or deterioration of the color of the restoration is less visible. Okay, but in certain cases, it is a must to approach your lesion from the facial or from the labial. Okay, in cases where the carious lesion is positioned facially, okay, for maximum conservation, you will access it from the entry of your caries. Okay, in cases where the teeth are irregularly aligned, especially when there is a crowding in lower anterior teeth, maybe it is much more conservative to access it from the facial or the labial. Where the carious lesion extends into the facial surface, okay, to a degree that undermines all the enamel and makes the enamel labially friable, then at this time you should open the facial area, or when there is a faulty restoration originally exists from the facial area. Your preparation is just selective removal of the carious lesion, pulp protection, bevel of enamel margin from the facial area, and final cleaning. For large preparation, you may require additional beveling or to increase the bevel to enhance retention by bonding. This is the area. First one is palatal or lingual approach, which is the most common one. The other one to the right is the facial approach.